to the PAT podcast. I'm Shafir Ahmad, your host, with new exciting episode. So stay tuned in. Please follow me on YouTube, Twitter and Instagram with the handle bar at Shafir Ahmad 4109. And please feel free to share these chunks of knowledge. Thank you. Today, the topic of our discussion of the podcast is another neurodegenerative disease known as Huntington disease. Now, before jumping into the detail of the Huntington disease, first of all, I would like to discuss the basic structure of the brain related to this Huntington disease. Now, as we all know that basal ganglia is a region of the brain, very important region of the brain, but one of its area known as striatum is important for our discussion for the Huntington disease for today. So striatum is basically composed of caudate nucleus and putamen, and in between the caudate and putamen you will have the internal capsule. So caudate and putamen is basically gray structure of the brain, and from the caudate nucleus GABAergic neurons lead towards the cortex. So on both sides of the brain you are having the structure known as striatum, and striatum is composed of caudate nucleus and putamen, and in between that is the internal capsule, and from caudate the GABAergic neurons are emerging out and they are going towards the cortex. So alongside the caudate nucleus you will also find the ventricles. So ventricles are lying adjacent to the caudate nucleus. So the structure is very important to understand the pathogenesis of Huntington disease, and hence various manifestations of the disease can be understood by just this simple figure number 1 in the handout notes. So alongside the caudate nucleus you will have the ventricles. Now from caudate nucleus are emerging out the GABAergic neurons, and GABAergic neurons are basically giving a inhibitory or negative signal to the cortex, and hence it is restricting the movements of the cortex. So it is important in the Huntington disease, because in Huntington disease there will be an atrophy of the caudate nucleus, and hence those GABAergic neurons will be damaged, and hence you cannot give a negative feedback loop to the cortex because of the loss of the GABAergic neurons. Now putting this all illustration of figure number 1 on one side, because we will come back to this when we will discuss the pathogenesis and morphology, let's briefly discuss the Huntington disease. So Huntington disease is basically an autosomal dominant movement disorder, and by autosomal dominant what I mean that one copy of mutated gene from one parent can cause the genetic condition. Then in the Huntington disease, the hallmark feature is the degeneration of the striatum, meaning that there will be the degeneration of the caudate nucleus and the putamen. And when there will be the degeneration of the striatum, so what will be the result will be the movement disorders. And movement disorder can present in the form of choreiform movement disorder, in which there is like dancing like movements of the extremities, or there will be the writhing movement of the extremity, also known as twisting movement of the extremities. So you will have two different sort of movement disorders. One is the choreiform, another is the writhing movement of the extremities, which are classically associated with the Huntington disease. Huntington disease is a progressive disease, and it results in death after an average course of like 15 years. So the symptoms it will display will be mostly cognitive, for example forgetfulness, thought and affective disorders, like there will be the mood disorders, and dementia can also progress in the disease. So due to affective disorders or mood disorders or behavioral changes, Huntington disease carries an increased risk of death due to suicide. So this correlation should be kept in our mind, because Huntington disease is increases the chance of suicide, and hence suicide we all know is not caused by a single event. First of all, a person goes into the state of depression, and from that depression it's a risk factor for committing the suicide. So Huntington disease is causing behavioral changes or causing mood disorders, and with that depression a patient can go and can lead towards suicide. So just giving an overview about the genetics of the Huntington disease. So this Huntington gene is present on chromosome 4 on P arm. So on chromosome number 4 you will find that Huntington gene, and in the normal Huntington gene you will find 10 to 35 cytosine, adenosine and guanine CAG repeats. Now these CAG repeats, as you are seeing in the figure 2 of my handouts, so you will see that the normal Huntington genes or normal HTT genes is having 10 to 35 CAG repeat units. So the nucleotides CAG, cytosine, adenine and guanine, if they are repeated up to 35 or 34, so it's a normal HTT gene. And when that gene will undergo the process of the transcription, enhanced protein will form. So the protein it usually form is known as glutamine. So that will be the normal protein when it is transcribed from 10 to 35 CAG repeat units. But when there is an expanded HTT genes, or you will have in that HTT gene section, you are having greater than 35 or 36 up to 100 repeats of CAG, then there will be the abnormality, because the CAG repeat should not be greater than 635. So then it will produce, instead of normal protein, it will be producing a diseased protein or a toxic protein known as the Huntington protein. And this Huntington protein, or having that polyglutamine chain, is what is causing toxicity, neurotoxicity in Huntington disease. So let's talk about the pathogenesis of Huntington disease. That Huntington disease is caused by CAG trinucleotide repeat expansion in a gene located specifically on chromosome number 4 P16.3 that encodes the protein Huntington. So the normal allele, as I have discussed previously, is having like about 11 to 34 copies of repeat CAG, but when there is an abnormality, the CAG repeats will be greater than 35, and sometimes they are up to hundreds. So the greater the number of CAG repeats, the more earlier the onset of the disease. So again, I am repeating this important point, that when there will be the greater number of repeats, the more the earlier the onset of the disease. So the earlier onset of Huntington disease is associated with greater number of CAG trinucleotide repeats. So there is another concept which is related with the Huntington disease, and that phenomena is known as anticipation. So what is an anticipation? So what will happen, that expansion of this pathologic CAG repeats can occur during spermatogenesis. So the paternal side transmission, when there will be spermatogenesis, there is an increased expansion of that CAG repeats. So paternal transmission may be associated with earlier onset in the next generation. So for example, the parent is having like 35 repeats or 36 repeats. So when they will produce the offspring, so during the process of the spermatogenesis, the CAG repeats will increase. So when there will be CAG repeats will increase, so what I have said, that the greater the number of repeats, the earlier the onset of the disease. So in the next generation, the Huntington disease will occur much earlier than the parent. So this process is known as, or this phenomena is known as anticipation. So again, I am repeating that expansion of pathological CAG repeats can occur during spermatogenesis. So parental transmission may be associated with earlier onset in the next generation, because the greater the number of the repeats, the more earlier the onset of the disease. So for example, the dad was having Huntington disease at age 50, and he was having CAG repeats, for example, it's just an example, was having CAG repeats like 60 CAG repeats. Now what will happen, that during the offspring, when they will produce the offspring, so during the process of spermatogenesis, so the parent is having, the dad is having 60 CAG repeats, and during the process of spermatogenesis, the repeats might increase up to the 80, 90. So the offspring will have 90 repeats of CAG. So what will happen, that instead of starting the disease at age 50, the offspring will have a disease of Huntington like at age 25 or 30, much earlier than the dead. So this is the process of anticipation. So Huntington disease is basically a disease of gain of function mutation, and that is due to the expanded polyglutamine tract in the Huntington protein, as I've discussed previously, that when there will be the increased CAG repeats, so what will happen, that there will be polyglutamine tract will be found in that Huntington protein during the process of the transcription. So what will happen, that will be the large chunk of the protein, it will be a bigger protein. So as occur in our body, when there is any large protein or trash protein, so the process of ubiquitination starts. So ubiquitination will start, and hence followed by proteolysis. So these two processes, when after tagging with ubiquitin and proteolysis, what will happen, that there will be the fragmented Huntington protein will form. So this fragmented Huntington protein will aggregate inside the nucleus and form the large intranuclear aggregates. And this large intranuclear aggregates of Huntington fragmented proteins that will cause the pathogenesis of Huntington disease. So what these aggregates of protein can do, they can sequester the transcription factors and hence hamper their function. They can disrupt the protein degradation pathways and can lead towards building of abnormal protein inside the nucleus or cytoplasm. They can disturb the mitochondrial function and can disrupt the aerobic and anaerobic glycolysis process, and they can alter the brain-derived neurotrophic factor signaling. So hence it can cause theoretically a variety of different processes through which the neuronal damage can occur. On gross examination, the brain is small and shows striking atrophy of the caudate nucleus and sometimes of the putamen as well. So pathological changes develop in medial to lateral direction in the caudate nucleus and from dorsal to ventral in the putamen. So what will happen, that when there will be the atrophy of the caudate nucleus, so if you just refer back to the figure 1 of my notes, so you will see that the ventricles are lying adjacent to the caudate nucleus. So what will happen, that when there will be the atrophy of the caudate, so ventricles will start enlarging. So this is in contrast to like for example, there is an increased CSF pressure, so then ventricles can enlarge, but here there will be no increased CSF pressure, but due to the atrophy of the caudate nucleus, what will happen, that ventricle will form a space and it will just start expanded and dilating. So ventricles are also dilated in the Huntington disease due to atrophy of the caudate nucleus. Then on microscopic examination, you will find the severe loss of neurons from affected region of the striatum. Medium-sized spiny neurons that release GABA, enkephalin, dynorphin and substance P are especially sensitive to this change, and they disappear early in the course of the disease. And what will happen, that as I've discussed in the start, when there will be loss of GABAergic neurons, so there will be the loss of negative signal to the cortex, and hence the cortex will be overactivated and can form those classical movement disorders of choreoform and everything type of movements. So along with this, you will also find that fibrillary gliosis, and gliosis is basically a non-specific reactive change of the glial cells in response to the CNS damage, but it will be more extensive than the usual reaction to the neuronal loss. Then there is a strong correlation between degree of degeneration in the striatum and the severity of the motor symptoms. So if there is a greater degree of degeneration in the striatum, the motor symptoms will be much more severe. And there is also strong association between cortical neuronal loss and dementia. So when there will be a lot of cortical neuronal loss, so dementia can ensue. And at last, we have to understand that in striatal neurons, intranuclear inclusions that contain aggregated of ubiquitinated Huntington protein is formed, just like discussed in the pathogenesis section. This concludes our podcast for today. For further questioning related to the topic, feel free to email me at shafirehman@hotmail.com.